Okay, I'm Dr. Elena Rios, President and CEO of the National Hispanic Medical Association. I want to welcome everyone to our National Hispanic Medical Association virtual briefing series. This is number 3, which we are going to focus on the COVID-19's impact on healthcare delivery. And I want to make a special shout out to our major sponsor tonight, which is AARP. We're very proud to partner with AARP, which is probably one of the oldest organizations dealing with the health of our seniors. And, you know, COVID has affected seniors in a big way. I know that we're not talking about old people. When we talk about AARP, we're talking 50-year-olds and up. But I think it's very important to have an organization that talks about the resilience of our wiser participants in our population. And we will hear from Yvette in a minute. I think that we also have a few other partners. I'm just going to mention the partners. Compassion and Choices is a partner. Our National Association of Latino Healthcare Executives is a partner tonight also. And we have several partners for the whole series, including Centene, Amgen, Pfizer, Anthem, and Aetna, and others. So let me just go ahead and get to our first speaker. We're honored to have Congressman Raul Ruiz, the chairman of the Healthcare and Mental Health Task Force of the Congressional Hispanic Caucus. He's a doctor, well known to NHMA. I've met him when he was a pre-med student at UCLA when I was in medical school. And he's here to give us a message by video.
Thank you, Dr. Rios, for that introduction. And thank you to the National Hispanic Medical Association for facilitating this important discussion on the disproportionate impact that COVID-19 has on the Latino community. I am Dr. and Congressman Raul Ruiz, and I represent California's 36th Congressional District. Before I ran for Congress, I was a physician working in the emergency department. And before that, I was a kid who grew up in a farm worker community and grew up in a trailer park the first few years of my life in the Coachella Valley. The issue of health disparities is very personal to me. It's the whole reason that I decided I wanted to become a doctor. I saw the pain and suffering of my family members, my neighbors, and my community, the same community that taught me so much about resiliency and taking care of one another. It is in this poverty and struggle that I became determined to become a doctor and eventually return home to help address the disparities in health that I witnessed. For those of us who have lived these disparities and made it our mission to fight for health equity, the fact the coronavirus has disproportionately ravaged communities of color, particularly Black, Latino, and Native American communities, is not surprising. It is not surprising that Latino, Black, and Native American communities have one of the highest transmission rates of coronavirus. It is not surprising that Latino, Black, and Native American communities are dying at disproportionate rates from COVID-19. And why is this the case? A lack of resources, lack of access to care, physician shortages, and culturally insensitive care all contribute to worse health outcomes, such as higher rates of asthma, diabetes, COPD, chronic cardiac illnesses, which are precisely the underlying illnesses that put an individual at higher risk of dying from COVID-19. So when a global pandemic hits, Latino communities whose living and working conditions often increase the risk of transmissions are especially hit hard. Latinos are more likely to be employed in essential jobs. They do not have the luxury of working from home. They have to go out into the workforce and risk daily exposure. I've personally gone out to administer COVID-19 tests directly to farm workers in trailer parks with a group I helped found, the Coachella Valley Volunteers in Medicine. And I understand firsthand the daily struggle of trying to stay healthy, let alone getting testing or treatment. At work, the conditions often don't allow proper social distancing, don't provide masks, and don't have proper hand washing stations or breaks. This all results in a higher risk of getting infected and then they go home. There, they don't have the luxury of self-isolating away from their family, because oftentimes in Latino communities, 3 generations live in one household, in a small trailer, a small apartment, or a small house. That's why you're seeing large rates of infections across families in the Latino community. The fight for health equity should never be an afterthought when we devise policy. It should always be in the forefront of our minds. When we provide aid in a pandemic, we must pay attention to our vulnerable populations, seniors, and people with underlying diseases. Yes, and also the working poor struggling to stay safe from COVID-19. By investing in these communities and shelters and community health center programs and financial assistance for families who lose a job, in targeted testing and contact tracing, we can help our most vulnerable through this pandemic. This is precisely the time to protect and expand healthcare access for everyone, especially those who are most vulnerable to COVID-19. The coronavirus pandemic has made it clear. We must fight for policies that help level the playing field so that everyone, no matter your zip code, race, or socioeconomic status, can have access to quality, affordable health care. Doing so helps prevent the spread of COVID-19. It is our moral obligation as healthcare providers and policymakers. Thank you, and I will turn it back over to Dr. Rios.
Thank you, Congressman, for those remarks. Ben? So now it gives me great pleasure to introduce one of our sponsors tonight, Yvette Pena. She is the Vice President for Multicultural Leadership and the Hispanic Latino Audience Strategy for AARP. Yvette?
Gracias, Dr. Rios. Hola y buenas tardes. Good evening. Welcome, everyone. As Dr. Rios mentioned, I am Yvette Pena, and I am the Vice President of Multicultural Leadership at AARP, and I lead all the Latino audience strategy at AARP, and it is our honor to sponsor this NHMA briefing session today. Dr. Rios, thank you so much and your team for your great leadership and your partnership. And to our distinguished panelists, we're so appreciative of your time and being part of this important discussion. I have the opportunity to briefly share with you the many ways that AARP is helping older adults and their families during this critical time via our advocacy efforts and providing free resources and in language too, as noted in this slide. In the face of this pandemic, AARP is here, presente, to provide you with trusted information, which you can find in English. And all of the websites are all on this slide, so please make note of them. AARP continues to fight for the 50+ population, working so hard to ensure that lawmakers are allocating sufficient resources to address the outbreak, especially the crisis and nursing care facilities. To date, more than 35,000 COVID deaths can be traced to these facilities. We fought hard for the $1,200 dollar stimulus checks and for the inclusion of those on Social Security. We've helped to secure a major funding for vaccine research, funding for doctors and healthcare providers, and expanded unemployment insurance benefits for those who are out of work due to the COVID-19 pandemic. But there is so much more to be done. And we have a lot of resources that will help you and your loved ones. And I just want to highlight some of them. We're working to support the more than 53 million unpaid family caregivers in the United States. We encourage you to visit our great websites, arp.org/caregiving and /cuidar in Spanish to learn more. In the midst of this pandemic, scammers are doing what they always do, using headlines and fear as opportunities to steal our money and our personal information. And at AARP, we're helping to fight this fraud. In the healthcare space, scammers are offering phony vaccines, cures, and sham COVID-19 testing. We encourage you to learn more about these scams to protect yourself at arp.org/the Fraud Watch Network. We're also innovating. We know that social isolation was a problem even before the crisis, and even more so now. So we've launched a platform called ARP Community Connections. It brings people together virtually, where you can find volunteer groups to help pick up your groceries, help provide financial assistance and more. You can log into arpcommunityconnections.org, and in Spanish, we call it Mi Comunidad con AARP. We offer the new AARP Friendly Voice program, which provides phone calls from trade volunteers to help people of all ages who are feeling alone. We're so proud to bring all of this directly to you. And we also have our teletown halls with top coronavirus experts, of which Dr. Rios has been a guest panelist.
Yeah.
We hope, yeah, it was a great panel. We really hope that this session will leave you more informed, because now more than ever, it is so important for us to be there for one another. And at AARP, we want to support you by providing the most trustworthy resources, because juntos es posible. Muchísimas gracias.
Thank you, Yvette. So now we're going to get started with our program. We have a few housekeeping rules. We'd like everybody to put your microphones on mute on the lower left corner of the Zoom screen. You can see your microphone. Please put that on mute. We also ask that you type questions in the chat box, and we will do what hopefully we can get to as many questions as possible at the end of the, at 8 o'clock. We'll stay on the call until 8:15. Our presentations are about 10 minutes each, so we should have enough time for questions and answers. This session is being recorded, and it will be available next week at our website, www.nhmamd.org. And we are also on Facebook Live. We have a continuing medical education being provided. And as you see here, there are no conflicts of interest. And you can go to claim your CAE by going to this URL. It's well, you can see it. I'm not gonna read it, and we will have it up on our website. We will send a notice to everyone that's on the call. Next slide. So let me just set the context. Today we're going to hear a little bit more about COVID-19, but from the perspective of the healthcare system, and just to remind everybody of what Yvette and Congressman Raul Reese mentioned, is Latinos are being impacted severely by this virus. Number of cases just in 3 states that are Hispanic are at the level of 60%, almost 56% in California, and yet we have a population of 39%. And the deaths in California are 45% with over that population. In New York City, the population is 29% Hispanic with 34% deaths. New York, well, I won't talk about New York State. Let me just go to Texas. Texas has 18% of its population is Hispanic with 41% cases and almost 30% deaths. Next slide. So what do we do about this? At NHMA, we're very much involved in advocacy in Washington, D.C. And as Yvette mentioned, we have all been busy this year with Congress members, Senate members, and their offices helping to write legislation, give ideas, and write letters of support. And at our website, NHMA has a government affairs website page with lots of letters that you can write and take action on. And Ben Milano, who's helping us tonight, is our government affairs staff person who can help you with making sure we use all of your input for our advocacy. Some of the main advocacy that you're going to hear about today is on how do we increase health equity. We need to target federal and state resources for healthcare and for the healthcare programs that we're going to hear about today. And we need to educate Latinos that they should use the healthcare services that are being funded by the government and being funded from our hospitals and clinics and programs so that they have better access to healthcare. We need to address the challenges of hospitals, telemedicine, and home health to meet the growing and increased Latino demand as more and more Latinos get sick. We need to train a more diverse, effective workforce. And lastly, we need to collaborate with all Hispanic healthcare professional organizations. And again, I want to thank Xavier for being here. He's the secretary of one of our national leading organizations for Hispanics who work in the hospitals. Next slide. So now I'm just going to go ahead and introduce our first speaker, and it is Xavier Villarreal, Board Secretary, National Association of Latino Healthcare Executives, and he is the CEO of the Healthcrest Medical Center in the middle of the country, Tulsa, Oklahoma. And Xavier, I hope you have a lot of Latinos to talk to us about too. I've been to Oklahoma, and I know there are quite a few Latinos and Native Americans there and African Americans, so it's a big city.
We do, and thank you, Dr. Rios. I am honored to be here and be a partner with the National Hispanic Medical Association on behalf of NALA, the National Association of Latino Healthcare Executives. I've been in healthcare, and particularly hospitals, for 23 years, so my goal is really to bring a perspective from the hospital environment. And so just some general overall discussions about kind of the impact that we're seeing on hospitals. First off, we are seeing that COVID-19 patients are hospitalized at a higher rate than what you would normally expect from maybe an influenza outbreak. Definitely impacting more of our minority populations and Latino populations. Oftentimes we're seeing this locally where there may be some confusion in the public about actual positivity rates. It's very hard to downplay the number of people that we actually have in hospitals. That number has continued to increase. We're currently right now, at least in our part of the country, seeing the highest prevalence of hospitalizations that we've seen since the beginning of this. It created an immediate overnight impact to hospitals and how we manage and take care of patients in our facilities. We were literally drilling on a Friday to prepare for this, and we got our first patient on a Sunday. By the end of next week, we had our unit was full. And so it was literally an overnight impact to us. And it has created a huge financial strain on hospitals and healthcare in general. So next slide. I'm going to talk a little bit about the immediate impact, and then I'll end kind of with the long-term impact that I see. And the immediate impact I'll focus on really revolves around visitation and patient families, the specific units we have in facilities and the impact on staff, educating our patients and community, and the impact on cost. So next slide. So visitation. So most hospitals across the country have moved to either a limited or no visitation policy, and a lot of you moved to a no visitation policy in the active COVID units. So this has fundamentally changed how we treat our patients and visitors. We have worked for years in hospitals to make them a more inviting place and friendly place, and overnight we've really gone to what you see in the picture. There is our station that we set up very early on that really stops patients at the front and kind of creates this barrier and kind of an unwelcoming place. We've created a drop-off and pickup process for patients. We've created cell phone lots, so similar to what you would expect in an airport. We ask family members to go park in a parking lot, and we'll call them when their family member's ready. What this has created is this has really created some communication that unfortunately happens with the patient's family at pickup and drop-off. And that is really a terrible way to communicate health information to patients and family. And it's really created a big stress for patients receiving care afterwards. We've again, we had to go to universal masking and adapt our waiting rooms. And specifically, this is having a huge impact on Latino families because we have historically utilized the family support system within the Latino community as a way for us to truly communicate and make sure that families and patients particularly understand what is going on to them with them from a health standpoint. So we've had to change a lot of how we do that. And a lot of that has been with use of technology, which a lot of Latino families don't have access to. So next slide. When I look at the specific units in a hospital, we've made them isolated units. So we've shut them down. We do not allow folks in there. The staff are having to go through a huge amount of work to get PPE on and off in the room. And as a result, these patients feel very isolated. The staff is having to batch activities that they do when going into the room. So they because it takes so much to get this PPE on and off, they go in and do a number of activities, and then they go out and remove that, and they may not go into that patient's room again for another, 3 or 4 hours. And so it's creating a huge isolation feeling for these patients, and oftentimes they don't get some of the preventative care and routine care that they need by just pushing a call button right away. We've created a daily screening tool. So if you look at the code that's there on the bottom right, that's a tool that we've used. That every employee, we ask them to scan that before they come to work. They have to take the temperature. They have to track some travel activities, and it just creates a lot of extra steps for our staff. And again, when we're talking about the Latino population, there's a lot of those employees that don't have access to phones and technology, and that's creating an extra burden on them. Next slide. And again, educating our patients and community. I cannot underscore this enough. This has been a huge issue. The spikes that have happened in our community have been tied to large gathering and businesses that reopen. They've been tied to multifamily, multi-generational housing, which again, as we said, impacts the Latino community. We can tie our spike almost exactly to all these events. And so it makes stuff like our next spike that we're expecting here and that we're talking about actively with our other hospitals in town is when school opens back up. Very important activity, very important for our families to get the kids back to school, but something that we're preparing for and expecting to see an additional spike here. On-site compliance is very difficult for us to get across sometimes to patients and families. It's hard to explain to them why we can't have visitors in, why we have a limited visitor policy. And then we are seeing a huge delay in care of patients who are just too scared to come into the facility. They don't know what's going on. They hear the news, they hear stories, and they delay care of stuff they should have gotten done very early on. The other thing from an education standpoint is really impacting our non-traditional avenues of connecting with patients. So normally if we needed to educate patients, we would look at different options, particularly in the Latino community, places like churches and schools and community centers. And that really, those avenues have been disrupted as well. And so it becomes a lot more difficult for us to get in there and really get into these avenues. So next slide. Just kind of a quick, so just kind of a quick impact on cost. We immediately saw lack of PPE, bleach, operating room supplies. There was a disruption in our kind of normal channels of how we got that. We're going to local factories to see if they can help us make masks and provide PPE for us. And then the pricing has been really elevated. If you look there at the chart on the right, you can see just an example. Before COVID, we used to pay for isolation gowns 22 cents each. These are our prices and what we get for our hospitals. Right now, we're paying $2.36 per gown. You can kind of go through there. We had masks that were at 51 cents each. We're now paying $3.58 each. So this has been an incredible spike in supply cost that truly is unsustainable. And the impact right now has been when you take that into account, you take the loss of patients that left because we had to cancel elective cases, the impact has truly been about $202.6 billion to hospitals across the country. For us specifically, within the first 2 weeks of this, we saw a $6 million immediate impact from it. And again, that's just not sustainable. So next slide. So what are kind of some of the long-term impacts specifically to hospitals? First off, it's the reopening strategy. When do you open? We struggle with, are we opening too quick? Can we truly establish the social distancing in waiting rooms? We're looking at stuff like testing. Testing is not readily available for us. We are truly seeing a shortage of reagent. We are looking at this every single day as a limited resource to know, are we going to be able to provide these tests for patients such as that are going through surgery or testing or pre-admission? We definitely can get the test for people that we have a suspect for, but some of these other tests that are really best practice, we're having a hard time getting. When we look at stuff like surgery patients, we try to justify the benefit versus the risk. So we've actually done, in our first month, we did 1,200 tests and only 4 positives came out of that. But that cost us about $84,000 for that month. So it's an expensive process, and we're trying to measure the benefit versus risk. We have a COVID-19 committee. That committee specifically, it is made up of doctors and leaders, and we're adding community members now. And what that allows us to do is really look at the different surges in the community, the limited resources that we have, and we make some tough decisions. Are these surgeries that we need to put off? Are there stuff that we need to close down? Do we need to shut down visitation or open it back up? So all of those are very, very tough decisions that we have to make, but we use that committee to do that. Next slide. Again, educating our patients and family. We have to use technology to do this, and that is a hard thing, particularly for the Latino community. They don't always have access to that, but it's very hard for us to get to a point where we are able to bring folks back into the hospital and feel comfortable about that. One of the hard things that's really not identified yet is how do we incorporate translation services into telemedicine? When a patient's in our hospital, we have a phone system that we can call a translator, and the staff member is communicating through the phone directly to the patient. We also use the family members of Latinos to help with that, to make sure they understand that. And that's been disrupted. So how do we incorporate a translation service and truly make sure that the patients and their families understand? Patient considerations, we're doing follow-up calls for the patients to make sure we've incorporated some COVID-19 questions. So when they leave after surgery, we call them back 3 or 4 days later and ask, have you had any symptoms? Is this something we need to maybe go back and warn some other patients that were in the facility? So next slide. And then the employee impact. Employees are it is a very, very hard position to fill right now, nursing is, in some of the clinical positions. We've looked to get some agency staff. Those prices used to run anywhere from 70 to 80. They're now up to 140, 150. And quite frankly, we just can't find them. They are going to the hot spots across the country. And because we're not necessarily staying ahead of this, it's more of a reaction, and we're sending the staff to where that hotspot pops up, and it's very difficult to get here. And even if we did, there's some staff that we were going to use from our sister facility in New Jersey. Unfortunately, there's some travel bans and restrictions on when they go back to New Jersey now, and so those all create difficulty for us to get staff. PPE, there's a lot of facilities that are truly stocking up on PPE to prevent outages. We are doing that. That creates another demand on PPE. As we get it in, we are trying to take advantage of every opportunity to get it in. And we're using some non-traditional supplies that we have to spend extra time really training the staff on. And then just kind of the last thing I'll end with is the difficulty in changing the strategies. We closed down in our state very early on in this. We shut down to elective cases. We've now reopened. Our leaders have basically said they don't want to go back to shutting down. And of course, we're looking around and we have the highest case counts since this started. And so sometimes that creates a lot of confusion for hospitals and healthcare providers to understand, if it was an issue 3 months ago, why isn't it an issue now with 3 times as many patients? So that does become a little difficult. And so really trying to understand that strategy and know that's been very difficult. But that's just kind of an overview of hospitals and healthcare, particularly hospital perspective on what we're dealing with.
Great, thank you very much, Xavier. Next, we have Sylvia Trujillo, who is the Policy Director and Senior Legislative Counsel for Compassion and Choices in Vancouver, Washington. Sylvia also was most recently at the American Medical Association, where she had responsibility for the policies for telemedicine, and she's going to tell us about that now. Sylvia?
Thank you, Dr. Rios, and also thank you for the invitation and your tireless work in this area. So as mentioned, I am with Compassion and Choices, the nation's oldest and largest nonprofit organization working to improve care and expand healthcare options and empower everyone to chart their end-of-life journey. And so this is a conversation that is very salient to the work that we do. Next slide, Ben, please. So before I dive into the impact of COVID-19, I just want to level set terms. So when you say telehealth and you're talking to a regulator, a payer, a clinician, a patient, they're all thinking of something different. So you can mean anything from audio only telephone, email, interactive video, an application on your smartphone like a patient portal, or remote patient monitoring using wireless devices that can automatically capture your vital signs like blood sugar, weight, and arrhythmia. And you also could be talking about different services. So it could be a mental health visit, it could be a healthy checkup, it could be for an acute condition. So when you're talking telehealth, you have to be very specific about the modality and the service you're talking about. Next slide. So pre-COVID, physicians and health systems and patients across the board, there was rising interest very quickly. There wasn't a commensurate rise in utilization. It was very low, largely due to state laws on licensure, medical practice, but most significantly, there were very significant limits on coverage and payment by state and federal public health programs like Medicare and Medicaid, as well as commercial payers. So just for example, Medicare limited payment for telehealth by law to individuals in geographically remote locations, and in only rare instances would cover it in a person's home, if you could believe that. These restrictions, however, did not necessarily apply for remote monitoring, so I want to be clear about that. But other problems that our prior presenter alluded and touched on have to do with inadequate broadband and medical grade connectivity to patients, and that's particularly true for our community. However, smartphone adoption is not a problem. While Hispanic adults remain less likely than whites to say they own a traditional computer or have high-speed internet at home, according to a 2019 Pew survey, Hispanics do own smartphones at rates comparable to non-Hispanic whites. Breaks down a little differently if you're US born or born abroad. 87% of US born Hispanics own a smartphone. Those abroad, it drops down to 69%. Next slide. But then COVID hit. This pandemic is an existential threat to our current in-person healthcare delivery model. As detailed earlier, the surge can overwhelm hospitals. Individuals can die alone without family in hospitals. Social distancing is very difficult, and hospitals and other facilities can become vectors for spread. This is not hypothetical. All of the foregoing happened in Italy and in some places around this country. Next slide, please. So the current global crisis notwithstanding, people are still living and dying from chronic and terminal conditions and diseases like cancer, and they need access to healthcare to avoid worsening of their health status, including premature and painful deaths. So in early March, state and federal governments, providers, and organizations like the National Hispanic Medical Association, Compassion and Choices, we knew telehealth presented the best way for patients to receive care in the safety of their home, for quarantine providers to continue safely practicing, for clinicians in other states to help mitigate shortages during a surge, and for ICU and palliative care specialists who were in very short supply, they could provide remote support to clinicians for in-demand specialty care from around the nation. For Latinos, it meant that, and it still means, we can find providers with language and cultural competence. OI Health is a great example of that. seek on-demand triage and guidance without going to the ED unless a clinician indicates it's necessary. And this helps us avoid expensive costs that we might incur if we're underinsured or uninsured, like so many in our community are. Next slide, please. This meant, I'm sorry, could you go back a slide just for a moment? I went too fast. So this meant that there were many state and federal policies that had to change very quickly. And you can see from this slide, many things had to change, but the most significant were those governing coverage and payment. But we saw a loosening of requirements for licensing, for HIPAA, for medical practice laws, as well as regulators announcing enforcement discretion. Next slide, please. So what did that end up looking like from mid-March to now? Well, Medicare lifted their restrictions on location, including home. And that means, for example, Medicare beneficiaries can now receive advanced care planning services via telehealth, which can be very helpful should a beneficiary become infected with COVID-19 and require hospitalization. As you can see, pre-COVID, 13,000 Medicare beneficiaries a week received telehealth. The last week in April, that was 1.7 million. 27% of them were Hispanic. So clearly a positive impact on our community, a positive access. Slide 8. I'm sorry, next slide. So again, I went too fast. So if we could back up one slide, I'm on slightly different slides. Okay, so you can see there, you saw a significant increase in commercial and Medicare claims as well. So you're seeing a trend. Next slide, please. So at a particular site, a particular provider serving the Latino community, the Virginia Garcia Memorial Health Center located in Portland, Oregon. This data provided courtesy of Serena Cruz. About 60% of patients are Latinx. At the start of pandemic, 1% of visits were via telehealth. They reached a peak in mid-April of about 75% of their visits via telehealth. More recently, they're running about 50% via telehealth. They plan to sustain these numbers, and they're working on workflows to transform their delivery of care so it's more accessible to the community they serve. Next slide, please. OCHIN, a data and technology nonprofit, works with more than 15,000 providers in 48 states and 105 federally qualified health centers. Their members' patient population includes over 5 million patients seen in the last 3 years, 26% Hispanic. 75% of the membership of their providers nationally successfully transitioned to providing telemedicine services as a result of COVID. Before the pandemic, less than 1% of their visits were via telemedicine. Today, half are done via telemedicine, and they intend to try to solidify that as a delivery model, particularly for the underserved members of their communities. So switching gears very quickly to the next slide, we have other digital innovators advancing new models that blend research, public health, clinical services, and community-based solutions. So the Pandemic Resource Network, a Community Health Watch, is a program out of Duke. It is designed to support people making decisions through the COVID-19 symptom tracker, utilizing daily texts augmented with telephone follow-up by clinicians when people have symptoms that are escalating. It's been rolled out across the country, available in English and Spanish, and they're targeting frontline workers who are not able to telework, and they have made outreach and partnerships with national Hispanic organizations like the National Hispanic Council on Aging. Others include an innovator out of New York called Radical Health, started by Latina, and it blends community health educator tools with tech. They're building a platform that supports meaningful conversations with AI-enabled tech that helps people understand their healthcare rates during a visit, build trust, and to help them do self-advocacy. So what are we looking at for the future? Next slide. Commercial and government payers are indicating that not all the flexibilities will be made permanent. Regulators, the same thing. So what can we expect? Next slide. Well, just as COVID-19 presents a major global challenge, there are national demographic changes that make it unsustainable to revert completely back to an in-person model of care delivery. The number of clinicians to provide services is not growing commensurate with the increase in demand. Current shortages are projected to worsen. Next slide, please. The median age of the US population is increasing, and the incidence of certain complex conditions are also increasing. This has a disparate impact on our community. For example, in the next 40 years, the number of Latinos with dementia will grow nearly 440%. We need to build infrastructure to support patient-centered care at home on demand that connects us to healthcare providers with cultural and language competence. Telehealth is not a panacea, but it certainly is part of the solution. So last slide, sort of rounding this all out and coming back to all the various policies that had to change. So next slide, that have to change. We are looking at regulations that are going to have to be modified, coverage and payment. We have to address liability issues and infrastructure, that last mile connectivity, and then providing professional support virtually in some instances to accelerate access and scale. So I thank you for your time, and I tried to cover the ground.
Thank you, Sylvia. And I just want to remind everyone on the call with us to please send us questions in your chat box at the bottom of your screen, and we will be asking questions of our speakers. And we are staying on until 8:15 Eastern Time. So next, our speaker is Diana Torres Burgos. Dr. Burgos is a Hispanic health advisor for our National Hispanic Health Foundation, and she is also the chair of the NHMA New York City chapter. Dr. Torres Burgos. You have to unmute your phone. There you go.
Thank you, Dr. Rios, I'm really excited about being on this panel, and I have a great interest as a preventive medicine public health physician in public health and vulnerable populations, such as the elderly who have been very much impacted by COVID, and also the services, that their ability to receive services at home. What is home health care and home care? I just wanted to go over a little bit because there are two types of agencies that provide these services, and there are differences. Home health care are agencies or those that provide medical services that are offered by a physician for a specific condition, illness, or injury. And these services usually require skilled care, nursing care, rehab care, such as OT and PT. And these services are usually covered by Medicare. As opposed to, on the other hand, home care agencies, they provide health services for individuals who are homebound. And this usually involves non-skilled personnel care, such as home health aides. And these are services that are not covered by Medicare unless they are getting skilled care at the same time. There are state Medicaid programs that do offer programs for the elderly, but again, it varies from state to state. There isn't one standard, there is no federal program in regards to home care. So next slide, please. So this is just a graph showing a summary of the differences between home and healthcare, and I think I'd like to give you an example to sort of show you the differences. A case example is if you have a patient with dementia who is in a hospital after a fall and sustained a hip fracture and is now ready to go home, that person is still requiring PT services, let's say in wound care services. That would go under skilled nursing care and rehab services. However, due to the dementia of this patient also has difficulty doing simple things such as bathing, dressing, and eating. So that would go under home care services. And so at that point, this person would be discharged home with both home health care and home care to be able to help them to recover from their surgery. But as soon as the needs for skilled care ends, so will end the coverage for home care. So if you have a patient with dementia who has, improved from their hip fracture, but they still have needs to be able to take care of their daily activities, that person, there are really 4 options that are available to families to be able to continue home care services. The first is that the family themselves will become the caregivers directly to take care of the families, which may not always be possible due to family needing to work. The second option is they can self-pay, again, which is another option which could be very expensive and not available to everybody. Some people do have long-term health insurance, again, very rare and also very expensive. And the last is the ability to apply to state Medicaid programs that exist but can vary in terms of eligibility and benefits from state to state. So why are home care services so important in our healthcare delivery? And there's a very simple answer, and that is that, next slide please. The population in the US is aging. By the year 2034, there will be more older adults than over the age of 65 than children under the age of 18. And this is shaping, we used to be a pyramid, we're becoming more of a barrel if you think of the epidemiology of our aging in the US. And it really brings up a lot of issues in regards to healthcare, finances, and everything else. And also the older population, those with pre-existing existing medical conditions were at increased risk for severe illness with COVID. And nursing homes were also found to be very vulnerable. Again, this is where a lot of our elderly receive their care. However, according to the CDC National Center for Health Statistics, the most common place for elderly people, those over age 65, to receive care was actually at home. As you could see, home health agencies provided services for 53.7% of all services provided for elderly over 65. When you look specifically at the age 65 for home health, 82% of them were over that age. So people are staying more at home and receiving more care services at home, which is why it's so, home care services are very important for our aging population. Next slide, please. And looking specifically at the Latino population, again, also aging. Right now, according to the US Census Bureau in 2017, the 8% of the Latino Americans over age 65 were part of the population, 8%, and that's projected to go up to 21% by 2060. So there is going to be a rise in a need for home care services. What was interesting and concerning was there was a report showing that in 2018, 1 out of 4 Latinos over the age of 65 lived alone. When you break it down by gender, that was 23% of men and 27% of women. However, the reasons as to why they were alone are multiple and not well known, but it is a concerning issue when you're looking at someone who may need assistance but does not have any support system to help them out. Next slide, please. Also, who is providing the home health care services? So when you look, this is a study that was done from New York City. When you look at the direct frontline workers, direct care workers, they're predominantly female, 86%. Break down their demographics, they're 30% Black or African American, 18% Hispanic, 7% Asian, 4% other. But when you look specifically at the home care sector, the highest number of workers are of color, 62%, and there's a high population of immigrant workers. 31% of the home care workers were born outside of the US. Unfortunately, you know, they suffer low wages, benefits can vary, and there are very poor, few opportunities for advancement for many of these workers. And what was interesting is they also looked at how workers got to work, and in New York City, 54% used public transportation, which we know was an increased risk for these workers. And so as a result, these were people that were also very much at risk, not only the patients they were taking care of, but themselves. Next. So what were some of the challenges for the healthcare agencies during COVID pandemic? I think some of these we discussed, but the biggest is just the care model. care model of home care agencies is to provide face-to-face in-home treatment, which is something we couldn't do during COVID because of, isolation, social distancing, and so on. So that was very difficult to do. In addition, during the peak of the COVID epidemic here in New York City, there was a lack of personal protective equipment and testing for the workforce. And that became a real big issue, because how can you safely have workers go into homes without potentially contaminating the people that they are caring for? So a lot of safety issues came up both for the workers and the patients. And in addition, the issues of if someone was presumptive COVID positive, and you had a caregiver that was presumptive positive, they needed to quarantine for 14 days. So who would then provide care for that patient? Fear was very, very much rampant during this time. There was refusal of families to receive home care services because they were just afraid that they would bring in the infection into the home. And there was also refusal by home workers to go out because they didn't want to go out into the public, go through the subway system to then, potentially, be infected through any of those public arenas, or even the patient and the patient's family, which unfortunately led to a workforce shortage. And so there was a lot of scrambling to get the services that were provided in terms of for patients at home that just became more of an issue. And this was real priority for those patients that were isolated, meaning they lived alone, family members were either out of state, and they had no social support. So what did you do for a family who depended on home health aid to be able to do just basic needs, food, medicines, basic dressing, eating, and so on. So that was another challenge that they had to work out as to how to best take care of patients who really were isolated. As mentioned before, there were a lot of regulatory issues that home care services need to do in order to get paid. And that includes doing assessments, and those are all usually in person. So they were unable to do a lot of things such as reassessments, initial assessments, in-home trainings, and so on. It was very difficult to transfer patients from the hospital who were able to go home because they couldn't really go in to be able to do assessments in the hospital and do the care plan to be able to get services at home. So that became another issue. An issue that really was in regards to billing is that as of January 1st of 2020, a new billing payment system went into effect known as the patient-driven groupings model, which is the first change in billing for home care services in the last 20 years. So just as people were trying to grapple of how to do this new billing, then they got hit by COVID. So these were some of the challenges, certainly not all that were faced, but some of the big challenges that were faced by home care agencies. And in terms of changes as a result of these challenges, next slide, please. The biggest change was really not being able to provide services at home and the implementation of telemedicine. That was the biggest change that was encountered. And usually a physician ordered needed to be had to be able to receive services. And the regulations were changed so that a non-physician providers such as a nurse practitioner can also order services. Also the ability to do telephonic health assessments where, as mentioned previously, that the idea of doing an exam, having iPads at both ends where you can actually have people do things to really do an assessment was a really big change, and a lot of training needed to be involved. And initially, there was no reimbursement for telemedicine use by home care agencies. So that eventually did get changed, and they were able to get reimbursed. Safety was a real big issue. So screening of patients and workers were done daily. So one of the things I know, I'm a caregiver for 3 seniors, and my mom has Alzheimer's and has home care. And so I was called and asked, are there anybody at home ill? Do they have any symptoms? And who would be the backup in case my home healthcare worker was not able to come. And then they would do the same thing for workers. They had to sign in and fill out a checklist to make sure they were not symptomatic, weren't able to go out and do work. Waivers were also instituted and suspended for reassessments, home visits, and in-house training. So that, again, was a change. This is all very temporary. We don't know how long this will continue. And in addition, finances became a really big issue. Hospitals and nursing homes are losing, but so are home health care agencies. According to the National Association of Home Care and Hospice, they did a survey and found that 15 to 20% of agencies report a revenue loss. I'm sorry, that home agencies are reporting a revenue loss of 15 to 20%. And there's a lot of uncertainty if whether more cuts are coming, because a lot of the funding is based on state budgets. And I know here in New York City, we are having major problems with our budgets because of all the expenses that had to happen to be able to manage COVID. So that has been an issue. But next slide, the reality is that as people age, they want to stay more at home in a safe and quality environment. So the demand for home health care is only going to only increase as population ages and more families opt to have care at home. And with that, I'll end it.
Okay, great. Thank you to all our panelists. And now I am going to ask a few questions. First questions I'm going to ask are targeted to specific speakers. And then I'll ask a few questions that anyone can answer. So the first one, Xavier, for you, about hospitals. You mentioned that hospitals right now with the immense COVID costs and all the burdens that you're facing, and imagine you're in Tulsa, Oklahoma. I mean, I don't know how big that population is, but when you have the biggest cities in the country, you know, whatever you're facing, they're facing 10 times as much. So for this picture of unsustainability, what do you need from Congress? What do we do next in terms of our advocacy for hospitals to stay alive? Any thoughts? What's the number one, number two issue?
I think a couple of key issues. There has been some CARES Act funding, which has definitely helped. You know, the idea of this PPE and the exorbitant cost of that, you know, from a leadership standpoint, it would be nice to be able to find a way across the country, instead of us having to try to hoard and buy some of this PPE. Is there a national strategy around you know, pushing manufacturers to really look at developing PPE differently? There are things that we just can't get right now, and we're kind of on a first come first served basis, and it causes us to really kind of make some critical choices. So I think that the CARES Act money has definitely helped. The idea of this telemedicine is definitely, I think, key. The more we can get Congress focused on that being a long-term solution for us would be a huge help for us.
Okay. And Sylvia, to follow up on telemedicine, you mentioned some innovations with the private sector. What do you think are some of the innovations from policy, the government sector, as Xavier was mentioning, what needs to be put in place for the long term for telemedicine?
So I think first and foremost, we have to have clarity around payment, right? Payment and coverage. Every provider is struggling. You have the hospitals, home health, and community-based physician practices are also really struggling, especially those that were not able to successfully and rapidly pivot into telehealth services. But I think we need clear payment policies that are predictable and are not overly prescriptive. So we'd like to see an extension into a permanent status of lifting the geographic and originating site restrictions in the Medicare program, because there are a lot of urban Medicare beneficiaries who live in urban areas that are not eligible for any telehealth services under the current law. And the only reason they can in this moment is because of the waivers that have been issued by HHS and the authorities Congress has provided during the public health emergency. So that's the first. I think next we have to look at last mile activity for underserved communities like ours, that in order for the promise of telehealth to be made real for underserved and under-resourced communities, we need to put the resources for broadband and wireless connectivity so that they too can enjoy the benefits of this new 21st century medicine way of delivering care. And I think last, we have to look at the real patchwork of state laws that govern medical practice and licensure. I'm not advocating national licensure. I'm just saying that the Federation of State Medical Boards and the licensing boards really should work not just on reciprocity around licensure, but they should work on standardization as much as possible around telehealth in their state, so that when the next emergency comes, because it'll come, we won't be doing what we were doing in March. I'm calling up the FSMB saying, you know, what are all the states doing? The surge is about to come and people need to know if they can help out from across the country.
Thank you, Sylvia. I just want to mention NHMA does advocacy for telemedicine, but again, Congress has been limited and moving slow over the years until we hit this very unique situation right now for us. But one of the areas that we have had advocacy with, and I have to mention it, is the whole idea of having access to prescription contact lenses, you know, by telemedicine, or by having better eye care, also psychiatric care. You know, there are different, I think there are different innovators that are way ahead of the curve in this business. So thank you, Sylvia. Diana, for home health care, it just dawned on me, you were talking about the immigrant workers in home health care. And I have to say that there's quite a few undocumented workers that are in the field. You know, our families are very strongly supportive of our elderly, as you are with your parents and parents-in-law. What do you think is the future? What can we do to help change policies for caregivers in the Latino community to have better, you know, better support? I'll just say that, better support.
I think there are various things. I think one is, you know, state programs vary. So what I can receive in New York to care for my parents is very different what I can receive in New Jersey. Mm-hmm. And it's all because it's Medicaid is, you know, state dependent. So I think, you know, trying to standardize more of the care for the elderly, and I think this is going to become a key issue with the increase in dementia. I mean, you're definitely going to have elderly there that are not able to care for themselves. The families are not able to because they have to work. And so who's going to take care of these individuals? And I think for, you know, so as a caregiver, I think we need to figure out how we can standardize and fund programs for elderly care. I think also just the idea of, you know, there are a lot of workers out there that I actually personally had a very hard time finding a Spanish-speaking healthcare worker in New York, which I thought was really, because of where I live, was very, very difficult. And that's the only thing that, and I had to go through several people and insisting on, I want to have someone who speaks Spanish and can understand the culture. Because once I did attain someone, you know, it made my mother so much more comfortable, and it made me comfortable so that I didn't have to worry as much, you know, when I was not able to be with her. So I think the ability of, you know, we have this population of immigrants that, you know, do understand the culture, can speak the language, and to give them the opportunity to be able to, you know, work and do good care for our families, I think is a great opportunity. And I think, how we work that out is sort of, in the politics right now, which is a very difficult situation right now. But I could tell you a lot of people are very interested in working in this job, but just, again, because of the issue of documentation, fear of being found out, and so on, it makes it a little difficult.
Thank you. So I'm going to open this up to anyone here, but the issue of the undocumented has come up more in our COVID series, obviously because we are a Latino organization. This question is about undocumented patients. Are they more likely to use telemedicine? What would you advise to be able to get more telemedicine for undocumented who tend to fear going into institutions like clinics or hospitals?
I was on mute. So I had to get off mute.
Yeah.
Well, that's in fact one of the reasons, right, that there was a big push for telehealth, because not only do you have undocumented persons in a household, there's a large number of households where there's more than one family member, and others may be reticent to go and access services, because we do see increased enforcement actions everywhere.
Mm-hmm.
And so telehealth is a way for people to have access to a clinician in a more affordable way. If they're uninsured, accessing a service like OI Health that's language appropriate, more affordable, and they're actually talking to someone who has knowledge and can counsel them, like, you actually do need to go to the emergency department. You can't wait. So it's the example used earlier where people are waiting until too late to show up in the ED, which can drive higher mortality rates. And so
Right.
Telehealth is one, but another one I mentioned, which was the Duke COVID tracker, symptom tracker, which is available in English and Spanish. It's interactive. You report daily. And if they see your symptoms are escalating, they actually have a nurse call you and have a conversation to see if in fact you may need to go to the ED. That's a public health research model that is very dynamic. It's new, it's subject to IRB, but it is very important for our community to push out a free resource from a reliable place that is not going to cost them money, right, and that is going to help them make good decisions.
I just want to add to that I think it's important to have also diversity of the workforce, because I know what was happening here in New York is that when people, were talking to someone via telemedicine and were of similar background, spoke, or let's say for a Latino spoke Spanish, and they were better able to convince someone you do need to go in there, because there was such a fear of going in, one, because they thought they were going to get the COVID. So they didn't want to go anywhere near a hospital. And so there was a lot of, having to let them know this is what's happening in our hospital. So I know Health and Hospitals did have a system where they were able to say, you can come in here, for instance, and get your shots, and you will be, and go through the routine saying, this is what's going to happen. This is actually, we have safety, measures in place so that you can receive your care. But it took a voice, from someone who is culturally competent to be able to say, I understand your concerns. This is what we have available, and you should be able to use it under these circumstances. So I think diversity of workforce is very important too.
No, that's very important. A quick question to Xavier, this one about hospitals, and as you have elective surgeries coming back, how do you balance the shortage of all the PPE and hospital beds in providing care for COVID, which is on the rise? And how are the Latinos or the Hispanic lives impacted by this this trade-off that you are obviously going through right now?
Yeah, but first and foremost, we direct all of our PPE to the COVID units to protect our staff, and that's really the main thing that we're trying to do, is to make sure that they don't ever go into a COVID unit without having adequate PPE. When we look at the elective cases, we have a committee, a COVID committee. We actually have surgeons go through a process where they look at each one of the they answer about 10 to 15 questions that kind of literally ranks the patient. So it looks at, you know, is this a patient that's going to be in the hospital a long time? Is this a surgery that could be put off a month and have little impact to the patient? And so we go through a list of those questions and we rank them, and we then have them on a scale, and this scale kind of slides back and forth depending on the amount of resources we have. So when we look at on a daily basis the amount of PPE we look at how many days we have on hand. So if that number gets very low, we can then adjust the scale and say, okay, the patients that need to have surgery, we can basically determine that these are okay to do, and then these patients need to be delayed for a month or two based on that scale. And we have physician input on that to help us determine that. You know, from kind of a Hispanic standpoint, I think from a Latino population here, first off, we do have I am seeing a lot more fear from some of our Latino employees in regards to particularly entering or going into those COVID units or where we know we have COVID patients. So the emergency department's a good example. And so where this has really been a huge impact is to ensure our staff that they understand that we're really using our PPE to make sure that we're protecting the staff where we know there's an opportunity for you to be exposed, but in other parts of the hospital, you may not need all the same level of PPE. So I think that's been that process, and us really reviewing this on a real-time basis every single day allows us to make those decisions as the amount of PPE goes up and down.
Can you just mention, I'm going to ask you, Xavier, one more question that came up about PPE. Do you think that the PPE is still going to have a shortage? Are we still having a shortage of PPE, and what do you think we can do about it?
Yeah, it doesn't seem to be going away, and it seems to be popping up. So where we our big concern at first was the kind of N95 mask and the specific mask that we wear into these units. We feel like we've gotten that. We're starting to use KN95 mask, which is a substitute. It's not quite an N95 mask, but as we've moved to that product, and we feel like we now got a little bit of better handle on the masking. Now surgical gowns are becoming a hot issue, and we're running out of those. And so what we're seeing is as manufacturers change their focus to different parts of PPE down the road, as in our normal course of business, and as we reopen, other parts of that supply chain get disrupted. So stuff like surgical gowns and surgical booties, stuff that we would normally have no problem getting, we just can't find right now.
Right. Okay. I have a question to the panelists. This is an ethical question. As we develop the vaccines, we've heard just today on the news, there's at least 5 vaccines now going into, stage 3 clinical trials. I think one of them was mentioned as going to be available by December. And this country is going to have to make a decision on who gets the vaccines. And what is your ethical opinion on a process or a protocol? Sylvia, I'll ask you first.
So I would step back from that question for this reason. I believe that we need a great deal more advanced care planning. And if we as a nation rolled out our advanced care planning tools across the board, it would allow us to avoid making those decisions as clinicians and as people who don't know the preferences and the values and what a family wants. And it's, again, not a panacea, but it's a much better option than getting this decision. And for our community, Dr. Rios, it's even more important because
let me just stop you there, Sylvia. We're going to run out of time right now, but I wanted to say that our next COVID webinar will be about what we're calling the new normal, creating these types of decisions on for advanced care planning. And the new normal of having more deaths in our family and having to deal with more issues. So I want to thank everybody. I'm sorry I didn't get to all of the questions. Ben, you tell me if I have any more time, but I believe that we're going to be running out of time right now. Ben?
I think we are.
I think we are. So again, thanks everybody. We have a CME for this event. This event was recorded, and you go to the www.nhmamd.org to see the recording that will be available next week. We were on Facebook Live, National Hispanic Medical Association, and you can find it there tomorrow. And I want to thank again Congressman Raul Reese and Yvette Pena from AARP for opening up. And I want to thank Xavier Villarreal from Oklahoma and the Latino executives, healthcare executives, Diana Torres Burgos from our New York City chapter of NHMA, and Sylvia Trujillo from Compassion and Choices. And I want to thank our staff, Vincent Garrity and Ben Milano, who have done an excellent job in bringing this to the attention of the participants. And to all the participants, please tell your friends to join us on August 26th. We will have our next COVID webinar. And then in September and October, we are going to have at least 6 or 7 webinars with a regional approach from our chapter leaders on COVID-19 and a variety of other topics. And then we'll continue our monthly COVID webinars in November. So next one is in August. So thank you all very much.
Thank you.
Thank you.